Good morning. For today's Emory Urology Grand Rounds, we have Dr. Brendan Browne, Assistant Professor of Urology. Dr. Browne completed his residency at Leahy Clinic, and he is Assistant Professor in Urology at Emory, working predominantly at Emory University Hospital and Emory University Hospital Midtown. Dr. Browne.
Thanks. All right, we'll go ahead and get started. Today's topic, we're going to talk about ergonomics and surgery. And this is, a topic that has a lot of interest from people who I've spoken to and stuff like that. And I never actually received a formal training in ergonomics during my training, but there were a couple of comments that I heard along the way that really put it in my mind, and then I continued to follow up. And the main one was actually from gastroenterology, the program director at Leahy, who essentially every year told the residents, if you are performing endoscopy, colonoscopy, whatnot, and you find that your hand hurts or your hand is going numb or you're having neck issues, you need to correct that now, because you're going to be doing scope procedures for the rest of your career. And it really, we educate people in how to take out a kidney and how to treat stones and all of these different things. But really, we're looking to build physicians and maintain the current physicians we have for long and vibrant careers. And, this is one of the steps that really can contribute to that. And I'm sure that many people out there know a physician who has had their, or any other business industry who's had their career cut short by some kind of injury. So we'll address that some today. Today we'll talk kind of about history, application in other industries, and then how it works predominantly in surgery. And I would like to I'll speed through to try and get to some of the insights and conversations from some of the other surgeons out there. So work-related musculoskeletal disorders are very common. You can imagine just about any body part can be injured with a rigorous physical profession. They account for almost a third of injuries that cause workers to miss days or illness. And then musculoskeletal disorders actually tend to require longer time for return to work than the average cause, contributing to massive economic issues or losses. When you compare across other industries, healthcare actually per full-time employee has a significant, number 2 in terms of how frequent these injuries are, and fits with some of the heavy, patient moving, as well as awkward procedures, et cetera. And specifically to surgeons, it contributes to missed work, reduced case volume. Sometimes people have to modify their practice to smaller or, less onerous tasks, less onerous surgeries, and then in some cases forced retirement. And I know a handful of physicians already that have had their careers cut short by neck injuries, hand injuries, etc. Workplace musculoskeletal disorders, when accumulated over and over and over again, lead to this concept of a cumulative trauma disorder. These are some of the risk factors for that. And looking at the list, you really see that a few of them are really echoed in surgery and the things that we do. And it certainly appropriately fits that this would be applied to surgical practices. Ergonomics has been around really since stone tools were invented and was refined through the 19th and 20th century. There's a longer definition, but essentially it is finding the most comfort in any of the activities that we do to streamline both tools, but also systems, including electronic medical record, assembly line processes, etc. So how far have we come? Since the advent of surgery, we look at the tools, and you can initially at first glance say, they really don't look that different. And, some of it from this 1850s surgical set is very similar because they are effective. But when you look closer at the picture on the right, you can consider, things like Castro needle drivers are really a significant refinement, or obviously power tools for instead of the bone saw have allowed decreased stress and strain on the surgeon. Another example is advances in the operating room table. On the left is Joseph Lister's operating table from Edinburgh in the 1890s. And this was considered a significant advancement from when people were just operating on flat tables or, patients' dining room tables. And now we can adjust patients in every conceivable fashion, upright, supine, prone, etc. And then this is probably the most pronounced that I could think of. On the left, you have a original candle-powered cystoscope that has now become endoscopic, laparoscopic, robotic instruments with infinite degrees, or not infinite, but 7 degrees of freedom and significant ergonomic benefits that we'll discuss in a bit. So, we have pop quiz. I heard there were 4 residents on. Any residents or anyone care to participate in an ergonomics quiz?
Yeah, I'll do it.
All right. True or false? Turning and arching your neck will move a cystoscope.
I'm tempted to say false.
I agree. It is false. In fact, it's mainly just moved by your hands. And, this is a joke to some level, but also it reinforces that we do put a lot of stress and strain on parts of our body that are not actually working towards the end goal of what we're working on. That's a lot of significant force on your neck that over time, with the thousands of cystoscopies and ureteroscopies that you'll likely do, really adds up. And, I also wanted to point this out, for every level of physician, because also you look ridiculous when you do this. So does ergonomics work? It does seem to, and the literature really has been within specific industries, but also, meta-analyses over multiple industries from, manufacturing to surgery, does show decreased sick leave and lost work days, as well as increased productivity, reduced costs, improved employee satisfaction. And it really should be thought of as a process and a continuous effort rather than just individual projects. But it can provide long-term benefits to any employees. So within surgery, it somewhat is more under the radar, and that's why maybe it's not as commonly discussed. And surgeons aren't really prone to complain, at least about pain. Maybe some other things, but a survey from the American College of Surgeons showed a fairly high rate of work-related injury, and that 50% needed medical care, but only 20% reported it to their institution, which I think is interesting when you compare it with 53% said that it had some impact on their operating room abilities or outcomes. And so this, really reinforces that this is about you as a provider and your ability to have a long and vibrant and productive practice, but also that in those times when you do have an injury, it is important to acknowledge that it could have effect on your ability to perform the best surgery that you can. Only about 15% of surgeons across multiple surveys have said that they received any sort of formal or informal ergonomics training. So, hopefully this maybe counts towards that for some of you. I'm still on the fence. But it's more challenging to devise an ergonomics training for surgery, and we'll get into why. It's not quite like, organizing your desk workspace. But is this low rate of training because surgeons just aren't interested? No. It seems that optional designed ergonomics training does get buy-in from surgeons, and it does show improvement in their practices and their general body strain. And so what do you teach in an ergonomics training program is a little difficult to say. Some of the feedback is that These are challenging because they're not as evidence-based as some of the things that we're used to dealing with. And that's born out of the fact that it's difficult to study in the operating room. You know, some of these sensors we'll discuss are heavier, they have wires in an area where we're supposed to maintain sterility. And then the subjective or survey studies have biases that are implied. You know, you can imagine you'd be more inclined to answer a survey if you had an injury. But we have to measure these things as best as we can in order to improve them and change them. So these are some of the measures. You know, personal evaluations, the NASA Task Load Index is a very well established and validated questionnaire that's been applied to surgery. You can see it on the right. It includes questions about mental, physical, complexity of the task, and then it accumulates a score. You know, you can use things as simple as smiley faces and frowny faces, or these third-person evaluations are more involved, where essentially you videotape someone in surgery and then a third person watches and scores the number of motions, the you know, angulation and extreme motions that occur, and then scores out based on that before and after ergonomic interventions. And then the objective metrics are a wide variety. You know, people have put any number of sensors on surgeons, assistants, perioperative nurses, et cetera, measuring, you know, muscle contraction, angulation, weight distribution and posture. And, you know, some of the more of the studies actually get some of this data from fundamentals of laparoscopic surgery or other simulation times, but they also do it in the operating room with carefully measured, and we'll cover some of the data in just a little bit. And not all surgery is created equal, which also is interesting. You know, some of these things are able to be applied across surgical endeavors in general, but each type of surgery, as people would probably readily acknowledge, has its own challenges, and there are certain cases or approaches where you might come out of it and say, oh, my shoulder hurts, or my side, or my back, or something. And, you know, each one has its own challenges. Again, this is, you know, reports of musculoskeletal disorders or injuries related to some of these, and probably reinforces some of that recall and sampling bias when you say that conventional laparoscopy has a 100% injury rate. So, you know, kind of reflects some of the challenges of the data, but I think that it still requires acknowledging. So we'll go through each subtype and kind of highlight some of the things that have been pointed out in surveys, some of the challenges, and then we'll kind of address ways that maybe we can improve some of them. Open surgery has challenges of working around teammates, you know, table attachments like book Walters that are in your way and challenge movement, lighting issues, and then headlamps or other, you know, weighted objects that are on your head, whether for sterility, magnification, et cetera, will add additional forces to neck and back. And then higher case volume often bears out, as you can imagine. The more repetitions you do of something, more likely sets you up for injury. Laparoscopy has its own unique types of challenges, and really this is the birth of laparoscopy, or at least an increase in laparoscopy was really when a lot of these ergonomic studies started to come out, and they were finding issues with more static posture, difficulties of poor instrument design where you are operating at a fulcrum and you need to apply increased force in order to move a similar tissue or grasp or things like that. You know, the table and monitor position, the tables were made for open surgery, and you know, they need to be adapted to laparoscopy. And in terms of risk factors, you know, one of the interesting things was shorter stature, smaller gloves was borne out as a risk factor, in that, you know, the instruments are not one size fits all. They are one size, period. So people have to adapt. There are issues of laparoscopist thumb, where you have like thin arm muscle injuries related to some of these grips that unfortunately have not particularly been adjusted. When you get into vaginal and perineal surgery, which is very common within our practice as well, you know, it's like you take open surgery and then you cram it into a smaller space. And so, that is working around team members, some of those same issues. There is the benefit that you often are able to be sitting down, but, still is a little bit of a challenge. And here, this is what I thought was a nice survey that emphasized that each of the surgical approaches has its own obstacles that are somewhat different across the board. And so, the workspace dominates the issues of vaginal and perineal surgery, whereas the instruments and the foot pedals within laparoscopy are more problematic, going with the idea that with a foot pedal, you have to bear weight on just one foot for whenever you're using it. And then it's important to remember that, you're not alone. Surgery is a team sport, and as much as there are significant stressors on the surgeon, there are also other and unique stressors on the assistant. And, for anyone who has assisted perineal or vaginal surgery, you can really appreciate that that would be the more problematic one for you, where you're reaching around, you're trying to stay out of the way of the primary surgeon who's working in a small hole, and it leads to some very interesting contortions at times. So, to the residents as well as to the attendings, acknowledge the physical stressors that are occurring with your other teammate within surgery. And then endoscopy does include a lot of the similar challenges that you would get in laparoscopy, but then you get the pleasure of wearing lead as well. With the development of robotic surgery, it was largely driven by, at least in my opinion, the desire to have increased degrees of freedom within the instruments that you're using to facilitate dissection, anastomosis, XYZ. And, in maybe fortuitously, they took that moment to also significantly improve a lot of the issues of ergonomics. You're now sitting with, the weight off your lower extremity, leading to decreased issues with foot pedals, much more ergonomically designed for posture. But interestingly, there are still challenges ergonomically with robotics, still issues with shoulder and arm, possibly higher hand strain. There is some reports of more eye strain, probably because you can't really look away from the monitor as easily. Interestingly, there were reports that there was less mental workload during robotic surgery, but I think that would be, just more of an interest note rather than anything we could really come to a consensus on. And so this, again, reflects that even with the 21st century technology and our best efforts to improve ergonomics within our practice, we are in a rigorous and onerous profession, and there are ways to reduce some of these things, but it's largely impossible to fully eliminate them from your practice. All right, quiz number 2. Anybody else in?
I'll do it.
All right. Is this hard or soft?
That is soft.
All right.
Soft.
Also soft.
Hard.
Hard, exactly. And so beyond just what we can do from body posture and positioning of things, recognize that, there are opportunities for OR equipment improvements, particularly in the form of leg strain with anti-fatigue mats. Shoe insoles, compression stockings have over and over again been shown to be beneficial both for physical, psychological stress across assembly lines, repetitive work industries, and surgery. And it is really interesting, at where I trained, you would ask for an anti-fatigue mat, which they had, and the the staff would be like, "Oh, you need your princess pad." And at first, you kind of bluster and say, "No, I'm a strong surgeon and I can take it." And then it's like, "Well, wait a minute, I'm going to be standing at this table for the next 12 hours, and I don't get any breaks." And it's something that don't listen to any of that feedback. This is your body, you get one, and the anti-fatigue mats can be replaced, the shoe insoles can be replaced, but your ability to stand is maybe limited. And this is even borne out in some of the Association of Perioperative Nursing guidelines, where they say that if you're standing for more than 2 hours or more than 30% of your work day, that you should use one or more of these things. Then we'll talk about lead. We wear this a lot during ureteroscopy, et cetera, and it's one of those, the aprons are certainly more available, but they do increase strain on your spine and lower back compared with the vest one, which can lift the weight off of your shoulders. And actually, one of my attendings used to take the apron and push or tape around the midsection so that it was tight and held on his pelvis and lifted the weight off of his shoulders. And I tried it a couple times. It's much, much more comfortable. And then also one other note is I've seen some residents and a variety of people who are at the start of a case, moving the patient with lead on. And you don't need to do that. That is, put the lead on when you need the lead and take the lead off when you don't need the lead. In terms of monitors, this is something that's gotten a fair amount of research based on laparoscopy. The optimal position appears to be directly in front of where your posture is working, 10 to 30 degrees below your eye level, and then approximately 60 centimeters so you don't have to lean forward to see the screen. That's for ergonomics and discomfort. Optimal task performance like suturing or grasping or moving actually was better right at the level of the surgical field, similar to what you would be doing with open surgery, where you look at the task at hand. And so I wonder if, two monitors stacked on top of each other could allow you to jump between those depending on what you're doing. And then there's some ergonomic devices. This one was one of my favorite, the Ethos chair, where, for pelvic laparoscopy, you sit on a chair that suspends you over the patient's head. I think that this has probably been replaced by robotic surgery, but, maybe not everywhere. But it reflects, that it really, this is an open space for thinking outside the box and different approaches. So there are some informal guidelines. The American College of Surgeons has teaching courses, but they don't offer any specific guidelines. And, you can, anyways, there's a lot, but I'm going to pick out some more specific ones and review those. So in terms of body posture, these are kind of the recommendations. And this is an interesting one in that we probably all think that, oh yeah, my body posture is fine. Like I do this, it's intuitive. I'm a surgeon, X, Y, Z, but, essentially the goal is to, keep your arms in tight, avoid large deviations that could put significant stress on you. In terms of equipment, this one is helpful in terms of a little bit more things that might be out of your considerations initially, such as reinforcing the anti-fatigue mats or supportive hose, the monitors as we discussed. In terms of the table height, it helps to set it to the height of the tallest surgeon, and then any, whether it be the assistant or the primary surgeon, and then other people use step stools. One of my attendings used to set up a platform of 6 step stools so that he was still able to move around. Don't feel limited to having just one step stool. And then that also kind of fits with the body posture as well. Move your feet when you're operating, turn your body, instead of turning your neck. And it really is helpful to reduce the longer term strain. And then behaviors is somewhat, are some of the more interesting ones that certainly, I don't necessarily consider all the time, but, possibly rotate sides during open surgery to balance out strain, intraoperative stretching. And there was actually a paper about micro pauses where they had surgeons take 20-second breaks every 20 minutes and tested fatigue and errors post-op. And it essentially eliminated the fatigue and error seen without the pauses. And then stretching is, before and after is helpful. Obviously, plenty of times we hear about yoga as a mental health and wellness benefit, but it also significantly improves core muscle strength, muscle tone, and can give you a little bit more flexibility. But any type of strengthening activities, likely would be beneficial. And we're not necessarily talking about, glamour muscles, but, ones that are beneficial. So I thought about some of these options and, trying to rank them as to what is things that you can do now, maybe to take away. And the first one is awareness. People don't generally think about these types of things because it's not taught. And admittedly, as I took a deeper dive into this topic, you notice the things that you're doing that maybe aren't the best, or you're like, oh, maybe my neck does hurt after I do this, or maybe whatnot. And so now you are aware. Hopefully, I didn't shatter the glass and make you question your decisions about being a surgeon. But it is a rigorous profession. Acknowledge your injuries. We talk about rest, ice, compression, elevation, and so resting is sometimes necessary, and whether it means in the form of taking a break from work if you need it, or reducing your outside work activities so that you can continue to do your challenging occupation, then acknowledge that. Reducing the strain in your other activities, whether it be your clinic, dictation, if you're having wrist problems, dictation rather than typing. We talked about the leg, anti-fatigue mats, etc. Stretching. Ergonomic timeout was an interesting one where you're identifying your patient and your planned procedure, but then you adjust monitor position and table height. And then in terms of, we're probably not going to get the ethos chair, but the micro pauses. There was, at one point during my residency, I noticed, whenever I attach a ligature or a stapler or something like that, and then it takes 5 seconds to coagulate or to fire the stapler load, I would intentionally relax my shoulders, relax everything, because with the recognition that as soon as while it's clamped on, you're likely in control of whatever you need, but you need to be ready as soon as you let it off. And so that was often my moment of relaxation during a surgery, but it was very informal and unstructured. So, but I'd certainly be interested of what some of the other surgeons do, and I'll open that up in just a minute to some of your insights. And then the last thing, I just want to mention, this disability insurance is something that's never really talked about to residents, and probably rarely. Periodically, I hope all of the surgeons out there have it. 2 important notes: try to get specialty, or definitely get specialty specific disability insurance, because it'll reimburse you at a higher rate than a general physician, going with your increased income potential. And also you have a higher risk of injury compared with an internal medicine doctor. And then many employers offer a baseline insurance policy that I think that the Emory one, I'm pretty sure, covers 60% of the income. It's often reasonable. I have an additional rider policy because the employer ones are then often subsequently taxed and may leave you with an economic or income shortfall if you're injured for an extended period of time. So that's it.